Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and I'm pleased to be with Dr. Richard Bulbulia, who is a consultant vascular surgeon at the University of Oxford and co-PI of the ACST-2 trial, which studied carotid artery stenting versus carotid endarterectomy and was a hotline presentation at the ESC meeting. Welcome, Dr. Bulbulia.
Hi, John. I'm pleased to be here.
All right, would you tell us the main findings of this very important trial in vascular surgery?
Yes, John, I think there were two main findings. The first concerns procedural hazards. And what we found was that the rates of death and disabling stroke, that is to say within 30 days of the procedure, were similar for both carotid surgery and carotid stenting at around 1%. Then considering long-term efficacy, the 5-year disabling stroke rates were comparable for both surgery and stenting at a rate of around 0.5% per year.
Now, tell us exactly who these patients were. And as far as I can see, it was a fairly long trial.
Yes, John, it was a labor of love. It ran for around 13 years to recruit these patients from around 130 sites across 30 countries, predominantly European. And thanks to the hard work of our network of collaborators across Europe and wider afield, we randomized 3,625 patients in whom carotid intervention was considered necessary by the managing clinician at these local sites to either surgery or stenting. We had quite broad eligibility criteria, and the inclusion and exclusion criteria were really left in a large part to the treating clinicians at these individual sites. And it was this streamlined design where we integrated trial processes into routine clinical practice that allowed us to complete the largest carotid surgery trial to date.
And can you say anything about important subgroups about the primary endpoint? Were there any particular findings there?
So in our Lancet paper, which is available via open access, we did some subgroup analyses on the main possible criteria that might influence outcome, and there were no significant subgroup abnormalities or differences seen in the trial. We're always a bit careful about subgroup analyses. ACST-2, as I said, is the largest ever carotid surgery trial to date, but it's not really large enough to look in a meaningful way into subgroups. And you do run the risk of getting data-dependent findings which aren't particularly reliable. We are collaborating closely with all the other major carotid surgery and carotid stenting trials, and we do plan to do an individual patient data meta-analysis, pooling the results of ACST-2 with the asymptomatic population in CREST and ACT-1, and perhaps with that IPD meta-analysis, which will give us around 6,000 patients, we might have the ability to look in subgroups in a more statistically robust fashion. But what we did do, John, is we looked at the results of ACST-2 in the context of the total available randomized evidence that existed before ACST-2, and we found remarkable consistency with our results when pooled with the other asymptomatic and indeed symptomatic trials of surgery versus stenting. That was a tabular meta-analysis, and obviously the IPD meta-analysis will allow us to do things in a little bit more sophisticated fashion.
Well, I suspect that there's been quite a bit of iteration in carotid artery stenting over the years, but it seems like in the past carotid artery stenting may have been reserved for higher risk patients, but what's different now about that technique compared to endarterectomy?
Yes, John. So the nice thing about doing a trial over 13 years is we probably capture and possibly reflect the evolution of carotid artery stenting. We noticed new stent designs being brought in as the trial went on. There were new embolic protection devices that were used as well, and also possibly clinician experience, both in the selection of patients and indeed technical skills in performing these procedures, almost certainly evolved over time. In contrast, carotid surgery, which has been around for almost 70 years, is a pretty established technique. and probably there's been few changes in that over time. But the important thing is these changes in carotid artery stenting may well impact on the procedural risks. The stroke rates and death rates and myocardial infarction rates seen within 30 days of the procedure, but they may not be terribly important in the long-term durability of surgery versus stenting, that comparison. And indeed, that was the most important comparison, I think, that we can get from a trial like ACST-2. Really, if you're looking at secular changes in carotid stenting approaches and indeed carotid stenting outcomes, it's probably wise not to look at a trial like ACST-2, which, although we have 3,600 patients, it's dwarfed in comparison to the large mandated national registries that exist in countries like Germany, where they have tens or hundreds of thousands of carotid procedures. Their outcomes are carefully recorded in these registries. And if you're looking at secular changes over time, go to the registries. Don't go to a relatively small trial, a trial where practice and patients probably may not reflect more widespread clinical practice. And indeed, the event rates in ACST-2 may well not be comparable or generalizable to routine clinical practice in the 2020s.
I want to get back to the generalizability of it, but I want to not take too long to get to the phrase that I really stuck out in my mind, which is patients were thought to require intervention. Now, as you know, there's some variability across countries about the treatment of patients with asymptomatic carotid stenosis, and certainly in the U.S. we do a lot of interventions for asymptomatic disease, but maybe in other countries medical therapy predominates. So, just to be honest, I would have loved to see a medical therapy arm of this, and I wonder how you would respond to that.
Thanks, John. I did some background research on you before this interview, and I'm aware of your views on asymptomatic carotid intervention. And yes, you're right. There's a huge variation in practice geographically. Rates go from 0% in Denmark to really quite high rates in North America. The ideal sweet spot is somewhere probably mid-Atlantic, I imagine. But you are right. ACST-2 did not seek to answer that question. That's not to say it's not an important question, it just wasn't a question that we set out to answer. There was some discussion at the very beginning of ACST-2 about having a third arm, but we decided against that, really for grounds of the impact that would have on recruitment. As you pointed out, it took 13 years to recruit these 3,600 patients. And if you throw in a third comparison, that just becomes a very difficult sell to patients. It's quite hard for patients to embrace the uncertainty of surgery versus stenting. If you add in an extra arm, surgery versus stenting versus medical therapy alone, it could really be quite confusing. And indeed, the experience of our German colleagues in SPACE-2 showed that they failed to recruit to that trial, largely on the grounds of complexity. And really, you need a big, simple trial to answer a question reliably, and that's what ACST-2 sought to do. I think if you look at the totality of the randomized evidence of intervention plus medical therapy versus medical therapy alone, that still does come down very favorably on selected intervention for asymptomatic carotid surgery, symptomatic patients, provided you can do these procedures safely with a low procedural morbidity and mortality rate. Obviously, my colleagues, Tom Brott and George Howard, and colleagues are doing CREST-2, and I'd encourage American clinicians to randomize patients to that trial. And then what we'll do is we'll pool the results of CREST-2 with ACST-1, ACAS, and the V8 trial. And perhaps more clarity will come about that. But I'm pretty certain that for selected patients, asymptomatic carotid intervention still has a role. And John, I just would like to point out that in this trial, the annual risk of these patients having a disabling or fatal stroke following successful carotid surgery or stenting was 0.5% per annum. So if we accept that successful carotid surgery or stenting will halve the risk of a long-term stroke, the background rate of these patients, had they not had a procedure, was probably 1% per annum, fatal or disabling stroke. So that's not negligible if you say you've got 10 years or 15 years of reasonable quality of life. That's quite a burden of risk to carry around because we know that successful surgery or stenting now halves that risk.
Great. Now, a quick question on where do these patients with asymptomatic carotid stenosis come from? Are these from screening facilities or screening programs or just routine practice?
Routine practice, really, John. I mean, in most of continental Europe and certainly in the United Kingdom, there's no appetite or market for routine carotid artery screening. And most of these patients came via the clinic, possibly a contralateral carotid stenosis in a patient who'd previously had a symptomatic carotid intervention, possibly patients who had some carotid artery imaging as part of a workup for neurological symptoms that were actually not carotid related, posterior circulation events or stroke mimics. Indeed, around a fifth to a third of these patients will have had some form of prior neurological event in the run-up to their surgery, either contralateral or non-carotid related. So it's perhaps not right to call these entirely asymptomatic. They're not recently symptomatic, but that wasn't quite as catchy a title as ACST.
Fair enough. And as far as generalizability goes, I know you made comments in the paper about the skill of the operator or the surgeon, and I'm sure that in ACST-2 you've got extremely good operational technique, and that does play a role into generalizability of this data, I suspect.
Absolutely, John. I think the procedural risks we see in ACST-2 may well not be generalizable to sites outside of a trial or to contemporary or future surgical practice or stenting practice. But the long-term effects on stroke reduction and particularly the proportional effects on long-term durability of these procedures probably do generalize both out with the trial today and to future clinical practice. So that's the take-home message, I think, for me, is that the long-term efficacy of ACST-2 is the unique result for this trial. The procedural hazards we see in ACST-2 are consistent with those you see in registries. But if you want to know what procedural risks are in the 2020s or 2030s, don't look to ACST-2, which is already historic as far as procedural risks go to large contemporary registries.
And then finally, as far as the translation of this, I mean, most patients probably, if they can be fixed with a less invasive stenting procedure and there's no real difference, they might vie for that. How would you answer that question?
Yeah, so the readout for me for patients and clinicians is this is a good result. It's a reassuring result. It's always good to have more than one way to treat a problem. And now we have carotid surgery and carotid stenting, which have been shown to be broadly comparable, both in terms of procedural risks and long-term efficacy. I think there will be strong patient preferences may come into play, but also there'll be patient characteristics that might push patients and doctors towards one treatment or another. And in those circumstances, patients and surgeons and stentors can be reassured that both procedures are reasonable ones to consider, and both can be achieved safely and with good long-term durability. I would also put in a plug for the long-term follow-up of ACST-2. We're going to carry on following up this population for a further 5 years, which will give us follow-up, a median follow-up of 10 years, and some follow-up out to 20 years for this large clinical trial. And we can do that at low cost, direct with patients via mailed questionnaires. And I think it's that long-term result which will be really, really key, because often the Achilles heel in endovascular treatments is long-term durability. And that's a question that ACST-2 with long-term follow-up is uniquely placed to answer.
Actually, I want to re-emphasize that for the listeners. That's really a remarkable thing about trials like this, because so many of the cardiovascular trials that we deal with 2 to 5 years follow-up, and anything more than 10 years is remarkable and laudable for sure.
Thank you, John.
Okay, well, thank you very much for being with us. Really appreciate it. And congratulations on your trial.
My pleasure. Thank you, John.